Ladies and gentlemen, may I have your attention, please? The live transmission will begin shortly. Please take your seats. As you're available, please turn off your cell phone or put them in silent mode to minimize interruption during the live transmission. Thank you very much for your cooperation. Good morning, everyone. One of the top international academic conferences in the Asia-Pacific region. Welcome to the TCTAP 2024. This is an announcer here in Korea, Moon Sodi. Before heading straight into our opening ceremony, let us stream a live transmission of our Asan Medical Center. Yes, on stage we are joined by the moderator, Dr. Antonio Colombo and Seung-Jung Park, and also panelists, Dr. Sripal Bangalore, Adrian, William Fearon, Hyo-Soo Kim, Jung-Sun Kim, Vincent On-Hing Kwok, Mamas, Kambis Mashayekhi, Duk-Woo Park, Gerald, Werner, who will be leading our live transmissions. And also the moderator will now lead the proceedings. So I would like to hand over the microphone to the moderator. Would you please start?
Thank you. Nice introduction. Thank you for that. Anyway, we want to start live case session 5 and from the Asan Medical Center. All right, Dr. Kang, can you hear me? Dr. Kang, can you hear me?
Good morning.
All right,
yes, I can
good.
hear you.
So we are ready. We really, have excellent, panelists and Alan Young as a moderator here. And so you want to start.
Yeah, thank you. I'm Dr. Do-Yoon from Asan Medical Center. It is my honor to present the opening case of the TCTAP 2024 in the Asan Medical Center. And he is my co-operator, Dr. Jinho Lee from Kyung University, and Dr. Soo-Yeon An, our senior fellow, intervention fellow. And Dr. An, can you please present our case?
Yes. We have a 61-year-old male referred for chest discomfort. He's taking medication for hypertension and hyperlipidemia. Next. The patient is a current smoker, and he presented with stable angina of CCS functional class 2. Next. Electrocardiogram showed a normal sinus rhythm, heart rate of 70 beats per minute, and there were no specific ST segment changes. Next. Chest X-ray showed no cardiomegaly, no signs of pulmonary congestion. Next. Echocardiography showed normal systolic function without any regional or motion abnormality. Next. LAO view shows a stenotic lesion in middle segment of RCA. Next. And we already checked FFR in RCA and it was negative. Next. The caudal view shows distal left main disease involving the ostium of left circumflex artery and LAD. And the circumflex artery is heavily calcified. Next. The cranial view shows diffuse stenosis in LAD. And the spider view shows interesting anatomy of distal bifurcation lesion. The ostium of LAD is severely stenotic, and there's a quite large ramus intermedius branch coming from the main branch. And the syntax score was 33 points.
As the patient is a 62-year-old male with angina, and the angio shows triple vessel disease, including left main. And the RCA FFR was negative, so we decided to defer the lesion. And the problem is the left main. In the slide, you can see that the left main is the degree of stenosis is the different by the view. In cranial view, it looks like just intermediate. And spider view, it looks a little bit more complex. And can you please give some comment or opinion for the treating, how to treat this patient?
Dr. Khan, I mean, your angiogram really illustrates the difficulty in imaging angiographically left main lesions. Sometimes it's very eccentric, it's very difficult to know the severity. Traditionally, we're supposed to call the worst view the stenosis severity. But you know, given a vessel that is the most important vessel in the coronary tree, I think we need better assessment of what exactly is going on in the circumflex, what exactly is going on in the LAD ostium. So some sort of physiology imaging testing next to sort out all that, all those lesions would be. What do the panel think? Anybody want to just go ahead and fix it, or do you want to do some testing first in terms of physiology, anatomy by ultrasound or otherwise?
Out of curiosity, I would like to know whether you included the RCA in your syntax score.
That's right.
You come up with 33, that would be debatable, left main plus syntax 33. But if the RCA, as you measured, is not significant, it should be taken out of the equation, which at the time of the syntax study was not the practice. So 33 with RCA or without RCA?
So Bill, what do you think, the functional syntax score here, or what do you think should be the score here?
Yeah, no, I mean, that's a philosophical debate whether we can apply syntax, because syntax had no FFR.
Right. No, I think that's a great point. And in the FAME-3 trial, we looked at the functional syntax score, which is exactly what you're referring to. And it was much better predictor and also allowed you to shift patients from cabbage to PCI. And if you had a low to intermediate functional syntax score, you could get an excellent outcome with PCI. So I think in this case for the left main, I mean, fortunately, there's not too much downstream disease. So I think you could get a pretty good assessment with the pressure wire about, the significance of the left main. And then obviously, I think imaging will be critical to help guide the approach.
I mean, I think the ostial LAD clearly here is significant. I think the biggest question to my mind is whether left main into circumflex is going to be functionally significant with pressure wire, because that really will change how you approach this lesion.
All right, Dr. Kang, would you tell us syntax score for particular
Yes,
patient?
the syntax score is calculated with the involving RCA. So I agree with the opinion with the Professor Werner that if we exclude the FFR negative RCA, the syntax score would be 28. And also the high syntax score is originated from the complexity of the left main itself. However, we don't know whether the RI branch is significant or not, and how we would calculate, if we calculate based on the functional test, the result will be different, I believe.
Okay, Dr. Werner, if you look at the syntax sub-study and main sub-study, even in the Excel study, high syntax score means actually concomitant to 2 or 3 vessel disease, right? It's not, just the representative, the complexity of the main disease itself. Actually, if you look at the, high syntax score in the sub-study, syntax study, almost 40% of patients had a 3 vessel disease. The remaining one is, 1 or 2 vessel, and mainly anatomical complex is not a big deal for the treat or not treat concerns, right? So if there are, 3 vessel disease, lots of the other epicardial disease, anyways, we have to consider unfavorable anatomy PCI, consider bypass surgery. However, anyways, I want to ask this one. Would you, how could you test surgery versus PCI still,
No, I would go ahead with PCI in this case,
PCI?
of course.
Okay.
This is a good case for PCI, isn't it? There's a leash of vessels, and actually it may well be treatable with a single stent, provisional round into circumflex, with treat the ostium of the LAD with a balloon. So I think it's a good case. It's a great case to start the meeting with, but a good case for PCI.
As another problem is that how to define the severity of the left main in this patient. So actually, according to the view, looks different. So we can measure the QCA or we can measure the FFR. So as yesterday, we introduced our new trial of the fate main that comparing angiography guided PCI versus FFR guided PCI in the left main coronary artery disease. And the patient was enrolled in the fate main and was randomized to the angiography guided group. So how do you think about the severity of the left main by angiography? What is the visually estimated diameter stenosis of the expert panelist? I want to ask you, because it's very difficult to define the number of the.
In your trial, you still can do IVUS, right, for the angiographic arm? Yeah.
Yeah. So we measured the QCA next. Yeah. QCA was different by the angles, and the cranial view had 70%, and the spider view, we checked the very, very worst view, and it was 80%. So I think it's the significant diameter stenosis, and we decided to treat the LAD by the FAME for the fate main trial protocol. And then I will describe what I did. This is the angiography of today, and the cranial view shows the not very severe disease, but I believe that it would be very diffuse disease on the prox LAD to mid LAD. And in caudal view, there is intermediate stenosis of the circumflex. How to treat the circumflex would be the key point of this patient. As Dr. Bennings commented, that we can apply balloon, or we can treat the circumflex with the stent. And then the mid circumflex has done some intermediate stenosis. And next, and spider view, the ostial LAD is very tight, and there is some intermediate stenosis of the high OM. But actually, I would concentrate on the big vessels, so I do not have the plan to treat the high OM. And I inserted the wire next, and evaluated the IVUS. And can you share the LAD IVUS with the cranial view?
Would you randomize the fate main trial?
Oh yes, the patient was randomized, and the randomized to the angiographic guided group. So I showed you the QCA, and it was over 50% and over 70%, and we decided to treat the patient, and did not measure FFR.
Circumflex.
Yeah.
Big artery.
And that was a septal branch, and this is diagonal branch and prox LAD.
Is that LAD one? All right.
Yes, here is the prox LAD, and the vessel size is more than 3.5, and here is the prox LAD ostium, and here distal left main. The wire from 6 o'clock was circumflex.
4, almost 4.
And here is the prox left main. There is free of disease. Can you please show again from the septal branch? Yeah.
There's fair amount of disease in LAD as well, in multiple spots. Yeah.
Yes, it's a distal left main bifurcation disease that begins with the shaft left main to mid LAD. And the most severe part is the distal bifurcation itself.
And quite significant calcification in some parts as well, so I think that will need to be considered in our decision making.
Yeah.
So, Dr.
And
Dr. Kang, in this trial, you usually have some strategy only based on angiography, or just modified the strategy based on the imaging?
No, only on the angiography. Angiography versus FFR-guided PCI, the decision of the left main.
So angio-guided, and based on the angio-guided, what would you do the circumflex, ostial part? And there are big OM branches over the words angiographically almost 50% narrowing. What would you do there?
Yes, angiography looks that the circumflex ostium has the intermediate disease, does not look very severe. And IVUS, there is a big opening of the circumflex. You can see from here,
Would you show us
you can
that?
see the opening.
Circumflex
Yeah.
IVUS though? All right.
Have you done a
Yeah,
circumflex?
so-
Yeah.
I evaluated circumflex IVUS also.
Yeah.
That's very important that the IVUS looks different imaging from LAD pullback and circumflex pullback. Can you please show the circumflex? This is circumflex pullback from the distal circumflex because there was some tandem region at the mid circumflex. So we did the pullback from as far as distal as possible from the normal vessel.
Superficial calcium,
Yeah.
luminary is quite good.
Yeah, vessel size is quite large, more than 3.5. And here is the proximal, near normal. And second OM comes from 12 o'clock, and first OM comes from 12 o'clock. And here is the ostium. Can you please show the ostium? Yeah.
It's quite favorable that all the branches come from the opposite side of the plaque, so
Yeah,
less
that's a good
likelihood
point.
of losing any of these
Right.
by treating the circumflex as well.
Yes, the OM has a very good sign that comes from the other side from plaque and with a good angle. How do the panelists think about the ostial circumflex? It has some quite severe disease or large plaque burden.
Yeah.
And based on the angio finding and IVUS findings though, right? Image findings and
Yeah.
what did you do there?
Yeah.
It's a good case for provisional, isn't it, for me? I think you've got an eccentric calcium in the proximal circ. Proximal circ's a big vessel, needs treating. So single stent down into circumflex and then reassess the LAD. The LAD is diffusely diseased with an early diagonal. The ostium probably needs some treatment. But if you start stenting the LAD, it could go an awful long way. You know, there's a lot of disease there. So I'd start off with a provisional single stent to circ and see how it gets on.
So the question is whether I think as SJ was asking, whether that you think this on IVUS, the circumflex origin, is significantly diseased or not. Because on the past, the sort of the side, when you pull back from LAD, looking at the origin of the circumflex looks
Yeah.
more open, but here it looks more diseased.
Yeah, very,
There's a big
large
plaque
plaque
there,
burdens are small
sitting at,
luminary
from-
areas. Quite
Yeah.
significant
One
stones.
important thing that we sometimes underestimate is the deep calcification there on the circ, right? Because you don't see that on IVUS. So you have really to think about a proper plaque modification, and even I think a shockwave is some really good opportunity here to go crossover left main circ to do plaque preparation for shockwave, to have a good stent expansion here, especially on deep calcification, because it might be that the stent probably is not perfectly deployed. So do you have shockwave available theoretically?
Unfortunately, the shockwave is not available yet in Korea,
okay,
so
okay,
yeah, I cannot apply it. That's
I
very good
understand, okay.
comment. Yeah.
I mean,
And
in this-
actually, I cannot agree with Dr. Benning's opinion to crossover from the left main to circumflex because the LAD ostium was severely diseased. So actually, I think that LAD would be more important than circumflex. So I want to keep the LAD open.
I disagree with my good friend Dr. Banning. It's not very often I disagree with him, but I will in this case. I mean, I would probably go with a two-stent upfront approach, but using the circumflex as the main vessel here, and then treating the LAD as a side branch. I think the disease in the LAD is complex. It's very calcified at the ostium. I wouldn't be comfortable doing provisional, which is quite unusual for me.
It is provisional rather than, it's a tiered approach. That's the important point here, that if you take a provisional approach, it doesn't mean you can't place a second stent, but it means you're not absolutely committed. And that's the problem with DK, is that you're absolutely committed to a two-stent approach up front. So what I'm saying is take a sequential approach, and if you treat the circ first, access to the LAD will be easy. If it needs a second stent, fine. We can put a second stent. It could be a TAP, it could be a clock, and everything is still open to you using a tiered provisional approach.
So Adrian,
Really, angiographic true bifurcation disease, LAD and circumflex ostial don't. So what would you do there, Dr. Kang?
Yeah. So we have so many debate even before the live case. So actually, I think that the proximal circumflex is very severe and that there is very high risk of the compromise, and circumflex is not small, it's quite large. So I decided to offer two stand for the left main that I'm very, with the technique that I'm very familiar with, just some mini crush technique. So I want to protect the circumflex and to keep the left main to LAD stand bigger. So I selected the crush technique with the upfront two stand. So
Adrian, you're talking about basically doing a culotte then, what you're proposing to the circumflex.
Probably. I mean, the challenge with the clot may be the differential size, but I think everything is open to you. And it's a question of whether you feel, I'm probably agreeing with everybody that the circumflex is going to need a stent. And therefore, it's an intuitive question about whether you think the LED needs a stent. My anxiety about the LED is rather diffuse disease over a long segment with an early diagonal. I would also say that there are 3 or 4 vessels coming off the main, and if we can get away with less stenting, that's probably helpful.
Yes.
So SJ, in Asan, the technique is mainly still mini crush, right? You don't do as much culotte or anything else, right?
We mainly prefer mini crushing technique. So it's some hybrid with high pressure inflation of a circumflex ostium from the concept of decay crush. It's not exactly decay, however, the high pressure after the stand and mini crush. That is
I want to ask the circumflex landing zone. Actually, I thought that the prox circumflex, the focal, the normal region would be good for the landing zone. But with the IVS image and the angiography image, the mid circumflex region is quite severe.
Yeah.
So if it, so how to cover or not to cover, we discussed a lot. And in IVS image, the mid circumflex region has the very severe plaque burden. And if we put the just stand at the proximal, that would be too short, they're less than 10 millimeter. So we decided to extend the stand to the distal circumflex to cover all region.
Yeah.
It can be too radical, but I think it will show the better outcome, not just better than just to put the disease there.
long stand. What length? What size?
It's 34, 3.0 by 34. Test.
I mean, the decision is already taken, but the mini crush has also one downside, that this intermediate branch might be a little bit more difficult to get for the rewiring. Could be, right? Because you have a lot of metal there then at the bifurcation. So probably my strategy would be more to go crossover. I don't know. I think it's too long.
Change your mind, huh?
No.
So there's a certain kind of fear that the LED gets occluded. Based on IVS, it's potentially possible, but I would rather go crossover. I mean.
You mean you put the stent in LED first and then?
No, I would do crossover left main and then do kissing to LED and then go for professional or culotte.
Do culotte separately. Put the circumflex all the way through the left main and then do that first.
I mean, we don't think that the circumflex stent is too long here.
I would say it's not long enough, Mamas. I would cover the whole left main and all that proximal circumflex vessel, and then go through that stent into LED.
Is the stent too long? In the IVS image, circ size is about 40. Now stent size is 30.
Stent size is 30. I decided it by the distal landing zone size, and we'll apply the bigger balloon for circumflex test.
But in the previous IVS image, mid circ size is about 4.
And there was, because there was still the disease, so I could not select the bigger one, because the landing zone, the lumen was 3.1, and the vessel was 440 deflation. So I will apply 3.1.
Stent lengthwise?
Stent length is 34.
34. I think it's a little bit longer than the expected 2 regions. You like a long stent, right?
I mean, the IVUS should be able to tell you what you see.
Concept is good. Full lesion coverage, etc. Anyway,
That is the point that the IVUS makes the lesion longer. And if we evaluate all the imaging studies shows that the IVUS group has the longer stent size, stent length, and this is a typical situation that when we evaluate the IVUS. And in angiographically looks good, but IVUS shows large plaque burden with a positive remodeling. Then we look for the better landing zone and the stent size becomes longer. And this is the same situation. With the angiography, I just planned 23. That would be too long, I thought, but with the IVUS image, actually, it was longer than I expected.
high pressure?
This is the next step, the optimization of the circumflex. This is 3.5 NC, as Dr. Kim said, that I will further dilate the circumflex. And here was the region, 1820.
I think this is a good technique to really optimize the circumflex before crushing, because a lot of times people just crush the one before stretching or optimizing the circumflex, then especially origin. Then you can make it really sort of not opposed and small, make it very difficult to wire and also not to expand it again well.
The maximizing the side branch ostium enhances the easy rewiring. And test.
I mean, that's right, Alan. This evolution of DK crush optimizes the treatment of the vulnerable spot. So it's an investment in making the next phase easier to get your wire back down, but also it's paying attention to the point where this procedure may fail.
1820. Deflection.
Yeah. Pulling back and a little bit further.
Yes.
Inside.
20.
Great. Perfect.
What
What size balloon?
This is 3.5 size balloon.
3.5. Not NC balloon, right? Must be.
NC balloon.
So.
And how effective do you think this is going to be in crushing the stent? Because the left main is a lot larger than 3.5.
Agree.
Yes, that's right. And the vessel size was 4.0 at the left main, and prox LAD vessel size was 3.5 or 3.7. So I couldn't apply 4.0 for the crushing because there was some gap between sides. So I applied 3.5 and did the maximum inflation. And the LAD scan, please. LAD scan, if we cover all regions, even in LAD, it is too long. So I will cover the region from the left main to septal branch, that there was some normal zone at the proxeptal branch. So I will cover with the one stent.
Should be long stent, right?
Sometimes, fix the left main first, and then you can evaluate again whether you need a distal LED stent. It's easier than putting a super long LED stent.
35?
Yeah, 3.5.
Size 35, length-wise.
This is 3.0.
Right.
Also 3.0 because the vessel size was not large in the mid-LAD. And I will apply the bigger balloon to maximize the size. Yeah, 3.0. Test. At the septal branch. Test. There's some negative remodeling at the mid-LAD, so I could not select bigger stent. Test. Test. Okay, I will put the stent at septal. Yeah, nominal. Deflection. Yeah, 16. 16. Yeah. Deflection.
LED stent.
To more bigger inflation of the proximal stent to avoid the guide-related injury, so I applied a larger size balloon, and I will use the 3.5 and 4.0 to optimize the prox LAD and left main. 4.0 짧은 거 하나 주세요. 4.0. 예, 이거 하고. 4.0 짧은 거. Because the left main size is very large, so we cannot optimize it with the 3.5. Luminance.
3.5로 올라갔습니다.
Deflation. The vessel, there was some tapering of the vessel size, 3.0 at sector and 3.5 at diagonal, proximal to diagonal. So I will use the diverse size of the balloon. 20. 24.
24.
24 atmosphere,
Yeah,
high pressure.
24. Yeah. Deflation. 26.
26.
Deflation. 4.0 짧은 거 하나 주세요.
Are you gonna do 4O balloon for the remain?
Yeah.
That's right.
Yes, all right.
Kind of
This is 4.0. And some short balloon.
kind of a part, you know, for the distal
Yeah.
remain and
That's proximal the stand optimization. It's the same concept with the part, but we know the IVUS and the vessel size, so I apply the bigger balloon, the proximal to optimize. Okay, 20.
proxy very,
This is
you know,
4.0.
proxy is quite
24.
good enough, big enough, and so
Deflation.
a bit further. Okay, good,
Nominal.
perfect. I think is it that right?
12,
Yeah. 18.
16, 18.
20. Deflation. And I believe that the proximal stand would be the optimized, and the risk of the abluminal wiring could be minimized, I believe. So I will undergo the circumflex wiring.
It's very classic, you know, two-stand
Yeah.
technique, mini crushing.
And after you've wired the circumflex, do you routinely IVUS to ensure that you have gone inside the lumen rather than extraluminally?
Actually, I do not do that. I just apply the size that I measured during the first measurement, and usually do not use the imaging
Yeah.
during the procedure frequently.
And that's less likely to happen with that ostial high pressure inflation in the first stent. I must have kind of, because they've done that, that makes that much less likely to happen.
3.5 주시고 3.0 아까
I
썼던
mean,
거
if you're not
주세요.
sure, running the LED to take a look at distal lesion, how much is left, and look at the left main, I think it's all reasonable too. So you can be sure that when you wire, before you wire the circumflex, everything is in good shape, and what else you need to do in the LED.
Yeah, with LED, there is some region that would be some. We checked the IVUS, and the minimal lumen area was about 3.0. Yeah, and there was some negative remodeling. So because the region is too low, and the plaque burden itself is not very high, so I want to treat it medically. And if there is some concern about the mid-LED region, we can check the FFR or after or left main PCI. And I believe that the prox region, big vessel, left main, is the key to treat the patient, and the middle region, side branch, distal region can be treated medically. That's our concept.
So Dr. Khan, in your trial, if he's randomized to angiographically guided, so can you use FFR to sort of determine whether the LED lesion distally is physiologically important, or you have to keep your FFR wire in away?
Actually, that is a little bit complex, but in this patient, the patient was the randomized to the angio group, so I did the left main angio, and then after to treat or not to treat mid-LED is up to the operator discretion. So operator can use the FFR or IVUS, any choice to treat the to treat or not to treat the mediated lesion. It's not.
One
there's no
technical,
restriction.
Dr. Khan, one technical question is the rewiring, right? So you just
Yes.
put the wire down. Do you have any concern? I mean, are you trying, because normally, technically, you can check in the spider view if you're near to the carina or more proximal where you're rewiring. Have you any concern about that, or you just do rewiring because you don't think that there's any clinical benefit wherever you do that?
Actually, I do not so much concern about the position of the rewiring. Some says distal, some says proximal, and DK guys says the proximal, and some other 3.5. Others says the distal. And actually, in the usual practice, that the distal or proximal, it's not very, we can do so many things. So in my personal practice, I try to go more distal for the mini crash technique, but I do not routinely check it and the rewiring in the routine practice. And I think that it is not very critical to change or to affect the patient outcome. The important thing is to open it the maximally to make the big lumen area. 3.0.
In case of T-stenting, we usually prefer distal rewiring.
Yeah.
In case of crush, proximal rewiring. In this case, you did actually a kind of T-stenting.
Yeah.
Micro,
That's right,
crushy,
yeah.
or T-stenting. Thus, it is easy to cross the side branch.
3.5, 6. As I think that the protrusion was too small, so that's why
Balloon, LED balloon should be a little bit further. All right. Anyway.
deflation.
Good.
This is a used 3-point NC, and because there was some distal lesion was small and this is 3.5 big, so I did.
What size balloon of circumflex was there?
Circumflex 3.0 NC that I have used before.
It's wonderful.
the
Even used
dilation.
balloon can pass the side branch.
Sure.
12,
Good.
18, 20,
18, 20,
24.
24,
deflation. 3.5 주세요. 3.5. 아까 used one 주면 됩니다.
Getting bigger.
Yeah, this balloon anchoring for LED, from LED.
It may be good to have a LAO view with stand boost to look at the status of the stands.
What size balloon are you going to use for the kissing?
It's 3.5 and 3.5. And
Both
this is
3.5?
Yeah, two 3.5.
2 3.5. Okay.
Because I have optimized the circumflex before, so I do not need more. I will just optimize the prox, and then this is the final step. And 3.5, 18, so for circumflex. Yeah. Deflation, 조금만 더 들어갑시다. Okay, 18, 20,
20,
there was some indentation, 22, deflation,
Big vessel. 3.5, 22
LED,
atmosphere.
20, 22, 4, deflation, okay, final kissing.
Yeah.
Okay, 10, 10,
2, 4, 6, 8, 10.
Big enough for the
3,
main
2,
side.
1.
35, 35.
How high did you go to in both balloons? 10, I heard, maybe?
Oh, it was 8.
8, okay.
Oh, it was 8. Yeah.
Patient seems to tolerate this inflations without
Oh, yeah.
problems?
Well tolerated. Blood pressure is okay. He has some chest pain, but it's not severe, so I did not give him any the pain reliever. 눌러줄래?
So are we going to do IVUS in both or?
Angio first.
Oh yes, I will check the IVUS in both. 됐어요.
Angio first, that's just JC.
이거 잠궈놨네. 프레셔 때문에. Okay. I forgot I locked the white connector for pressure monitoring. Okay, it's more smooth now. And check the angio. Test. Okay, angio.
I like that.
Okay, IVUS. IVUS for circumflex.
Could you show us a spider
view.
door?
Yep. Spider.
More dramatic, separate with the LED and stuff.
And you can see all the OMs.
Test.
Look good.
Okay.
Perfect.
angio. 잠깐만요. 네, angio.
Perfect.
There's some slow flow of the
the first
highest OM.
All the
And-
branches are,
Yeah.
survived.
Good
So, big OM,
Yes, I will
second
give
OM.
some nitro and we'll check the flow again. And the patient is not symptomatic at all now.
Also the diag, you have still some work to do.
Yeah.
Are you going to try to wire
So
that intermediate?
would you show us IVUS though?
Yeah,
We
I will
have-
check
yeah.
the IVUS
5
for
minutes.
circumflex first.
You
Oh,
may-
yeah. Oh, I'm a little bit late. Sorry.
So if the OM one does not improve in flow, would you try to wire it and balloon it?
Yeah, that's the consideration that do we have to treat the OM or not if the flow is still TIMI2 and patient is asymptomatic. But because the shape is not good, I would apply the wire, and the DCB is a good choice for them. And I will check the flow after nitro. Yeah. Because in many times after nitro injection, the flow goes well.
Yeah.
But side branch ballooning may distort the frame of the circ stent. That may
Yes,
lead
you're right.
that may lead to the stenosis.
Circumflex first.
Personally, I just let it alone.
Yes, I 100% agree with Dr. Kim's opinion. As Professor Kim said, that made some damage, especially it's very close to the left main, so I do not want to touch the branch so much.
Distal landing is good. Yes, stent expansion is good. Almost perfect. More than, how can I say,
And I
like
applied
7,
3.5
8
from
millimeters
here.
there.
Yeah. There also the mid calcified lesion. Here was the mid lesion, and where the dilated over 3.5. And here's the
Big
proximal. You can see OM, and first OM opening is where you can see in the eyes. And here's the
Overlapping
opening.
area is good.
There's some carina. Yeah.
Mini crushing, in terms of mini crushing, we like that one is relatively, small part of overlapping of the two stand and a little bit different of the hollow technique,
4.0 맞추세요.
So you have to review the IVUS. There are two OMs, and the first is completely covered by the crush, mini crush. So the second OM is okay, but the first not.
네, 한번 보여주실래요? First OM, can you please show the first OM? Yeah, full back.
So when you go back, yeah, this is the second OM. It's good.
The second
And
OM.
this is the first. Have you seen it?
Yeah. I think the OM is not covered. 좀 뒤로. Yeah, that is the OM.
There's the
Is the
second.
OM?
Yeah,
That's the first.
that's the first.
No problem.
Yeah.
Absolutely no. Good.
And after the side branch, the IVUS, I could see that the left main ostium itself stand needed more optimization and make some bigger to further the safety and for the future procedure. So I will apply 4.0 at the opening of the left main. Okay, nominal.
Yes,
Okay.
previous casing ballooning did not touch the proximal part of left main stent.
Yeah, ablation. Yes, I think that the corner is far distal to the balloon. Okay, once again, 20. Okay, here. Yeah, 24. Deflation.
Balloon size 4.0.
4-0.
4.0. Yeah.
I mean, even the plaque is on the opposite side of the wall, but you can see that so much plaque, when you put a stent in, it's just going to surround it, and also the crush from the top coming down, so that's two directions. Instead of pinching the first.
It's difficult to revive.
Final.
2 minutes
Yeah.
left.
Oh yeah.
So
I will
you have
show you
to
the final LAD
IVUS
pullback of the IVUS.
LED
Yeah.
dose.
I will check the OM whether it is safe or not.
The results is really wonderful, beautiful. Yeah. Circostim is
Yeah,
well
okay.
expanded. Yeah.
Okay.
And
Just
septal branch, and stem was placed at the septal branch.
landing zone is good. Just a landing
And
transition is good. Stent expansion is good. 3O minimal stent diameters.
yeah, here was the tightest region that had a head plaque burden, and the circumference comes from the fiber plaque. And I applied 4.0 from here. There's some plaque protrusion, and it's not so severe.
3, 4.
No mechanical carina. It's
12.
wonderful T-stenting. Yeah.
It's great.
Perfect.
Left main looks good.
Nitro?
So final injure.
Yep.
Maybe a spider.
Why out?
Thank you.
Yeah. And zero. Oh, sorry. Flow is good. I will check again. Yeah.
Okay, okay.
Test. Okay. Angel.
Perfect.
Better flow.
I like it. Another view?
Yeah, another view. The cranial.
Yeah.
Okay. Angel.
I like it.
Angel.
Okay,
This is
perfect
final.
result. Dr. Kang. So any other comment on that one? Okay.
I think, I would probably do a little ballooning of the OM1. The lesion origin looks pretty tight and it's a large OM, but obviously we don't have to do it now, but I think that might be what I would do. And maybe DCB after that, just get a little treatment. But this is, you can do a little kissing with that as well. But I think that's just cosmetic to try to make things better, but likelihood is not going to make a big difference with this left main fixed. But
I mean, if the patient says
people would attack that OM1 or leave it
Yeah,
alone?
I think you could touch it up and then you could still finish with a kiss and avoid deforming the circ stent and yet leave the OM with better opening.
Yeah, I think it's a little quite a bit pinched in the OM1. It's a big one. I mean, 2 and 3, I don't really care, but that one is a little big.
Yeah.
Dr. Khan, thank you so much for a really very illustrative left main case, and we enjoy very much your approach, and I think everybody appreciate how great the result looks like, and thank you so much for doing this case before our formal opening.
Yeah,
Thank you
so much. Thank you.
Thank you very much. We'd like to invite Charles back, and thank you very much to all the doctors and professors from Asan Medical Center, Adrian, and also to moderator and panelists. Thank you very much for sharing with us their helpful insight and also excellent live case session. Thank you very much once again. Now, everyone, we'll take a 5 minutes break, and would like to begin the opening ceremony of TCTAP 2024 in 5 minutes. Please join us. Thank you very much. I'll be back.